Think forward. Think Research Channel.
To try in an hour to talk about risk factors, prevention, diagnosis, and treatment of breast cancer is quite a task. And I can promise you that given the spectrum of topics that I'm going to be talking about this evening, there's actually more I'm not going to be talking about than that I am talking about. And I freely acknowledge that I will give you a fairly selected view of the world as it relates to breast cancer. And I do have potential conflicts of interest to disclose to you this evening that touch on the different things I will be talking about. I do consulting and have grant support from AstraZeneca Pharmaceuticals and have done consulting in the last year for Genentech, Pfizer, Novartis, and Genomic Health. So if we look at breast cancer in the United States, it's an enormous health problem. The American Cancer Society estimates that in the year 2006 that there will be almost 215,000 new cases of breast cancer in the U.S., and that about 21,000 of those will specifically be from California. There will be over 41,000 deaths from breast cancer in the U.S., and somewhat over 4,000 of those will be in California. This shows the age-adjusted cancer incidence for women in the United States from 1975 through the year 2002. And as you can see, the incidence of breast cancer has relatively steadily increased over this time frame. If we look specifically at different regions within the United States, we can see that the San Francisco Bay Area, shown here, has one of the highest incidences of breast cancer of any area within the United States. Only Connecticut has an incidence of breast cancer higher than the San Francisco Bay Area. This shows age-adjusted death rates from cancer in the United States from 1930 through 2002. Breast cancer is shown here, and as you can see, recently over the last decade or so, we're beginning to see a decline in deaths from breast cancer in the United States. This blue line here shows deaths from lung cancer and bronchial cancers. And so one of the messages from this graph is that if you're here this evening because you're worried about breast cancer and you smoke, you're at the wrong lecture. This shows the U.S. Breast cancer incidence and death rates now from 1975 through the year 2003. Incidence is shown in the yellow line, as you can see again, a gradually increasing incidence, perhaps a little suggestion of a declining incidence over the last few years, but we're seeing a steadily declining death rate from breast cancer in the U.S. The reason for this is not fully known. It is likely both related to increase in screening for breast cancer, so earlier diagnosis, as well as more effective treatments for breast cancer. One of the messages in this slide also is that most women who develop breast cancer do not die of breast cancer. A breast cancer diagnosis is by no means a death sentence. While breast cancer is a major problem in the United States, and there's the belief that breast cancer is a problem of the developed countries, as this slide shows, breast cancer is as frequent in the non-developed countries of the world as it is in the developed countries. So the developed countries are shown in green, about 190,000 deaths from breast cancer, 636,000 cases of breast cancer per year, and in the less developed countries, actually more deaths, 221,000 deaths per year, and about 500,000 new cases of breast cancer. So breast cancer as we view it today is truly a global problem. Well, if we look at the incidence of breast cancers over populations, what can we say about an individual woman's risk for breast cancer? So there are a number of well-defined risks for breast cancer. They include being female. Breast cancer does happen in men, but it's much less common. Breast cancer increases in incidence and frequency with age, especially age over 25 years. There are two mutations known as the BRCA1 and BRCA2 mutations that if a woman has it, greatly increases her risk of breast cancer and ovarian cancer and several other cancers. A positive family history increases risk for breast cancer, and in terms of family history, the closer genetically the individual is, the younger they are in age, and the more relatives with breast cancer, the greater the risk. There are also benign breast diseases that are known as the proliferative breast diseases. These are things like hyperplasia, atypical hyperplasia, that are associated with an increased risk of breast cancer, even though the lesions themselves are benign. Being young at first menstrual period is a risk factor. Being older age at first birth is a risk factor. Older in this context means over about the age of 25 to 26. Late menopause is a risk factor for developing breast cancer. Having had a prior breast cancer increases greatly a woman's risk of developing a brand new breast cancer in the other breast. And a woman having had prior radiation therapy, especially radiation therapy to the chest, as for Hodgkin's disease, increases the risk of breast cancer about 20 to 30-fold. There are also a number of minor risk factors for breast cancer. Race impacts the risk of breast cancer. Women of high socioeconomic status have an increased risk of breast cancer. High education is associated with increased risk of breast cancer. Being tall, being obese are risk factors for breast cancer. Hormone replacement therapy is a risk factor for breast cancer. Sedentary lifestyle is a risk. And alcohol consumption is also consistently a risk factor for breast cancer. About half a drink a day is enough, so half a glass of wine, half a beer, half a shot of hard alcohol, on average every day is enough to measurably increase a woman's risk of breast cancer. And there's a pretty steep or consistent dose-response relationship, so twice as much alcohol is twice as bad. I'd like to switch very briefly to look at some of the issues around hormone replacement, because I know that's been a major issue in the news. So the study was known as the Women's Health Initiative, and what it did was it enrolled postmenopausal women and gave them treatment with either placebo or hormone replacement therapy. The type of hormones that were given were decided by whether or not the woman had had a previous hysterectomy or not. Those women without a uterus were randomized to either conjugated equine estrogen, known widely as Premarin, or to a placebo, while women who had not had a hysterectomy, so the uterus was still present, were assigned to either a conjugated equine estrogen and a progesterone, or to placebo. And the combination here is widely known as Prem-Pro. So this figure shows the impact of these hormone replacement strategies on breast cancer risk. On the left, we see the estrogen plus progesterone, and the active treatment is in the orange bar. And as you can see, the risk of breast cancer was increased about 24% relative to placebo with hormone replacement therapy. If we look at the impact of estrogen alone, it looks like there's a slight decrease in the incidence of breast cancer, although this difference is not what we call statistically significant. And so it's quite likely that this finding is a chance observation and not a true finding. So at least it looks like the combination of estrogen plus a progestin increases a woman's risk of breast cancer. So when we look at risk for breast cancer, one of the issues we are confronted with is what can we modify to impact a specific woman's risk of breast cancer? Well, things that are under a woman's control are age at her first child's birth, her alcohol consumption, her socioeconomic status, her educational level, where she lives, whether she's obese or not, whether she takes hormone replacement or not, and whether she exercises or not. The problem here, of course, is that if we want to minimize breast cancer, we should encourage all of our daughters to get pregnant in high school, to drop out, to be teetotalers, to be poor, to live in the country, to be anorectic, and to be marathon runners. And these are the sorts of risks, though, that we see from breast cancer are not the sort of risks that women are likely to make these sorts of life decisions based upon. So that these risk factors, for the most part, are not modifiable. And that has given rise to the concept of so-called chemoprevention, Are there interventions that we can do that will decrease a woman's risk of getting breast cancer that don't require these sorts of lifestyle changes? One of the agents that has been looked at and that got this area going is an agent called tamoxifen. Tamoxifen is a very complex drug. It's what we call a selective estrogen receptor modulator, and it has both estrogen and anti-estrogen effects on the body, and whether it's a predominantly estrogen effect or anti-estrogenic effect depends on the organ that you're looking at. So relative to the breast, tamoxifen functions as an anti-estrogen. It's widely used in the treatment of women with breast cancer and is one of the most active agents that we have in that context. One observation that came from the studies in women with breast cancer was that women who took tamoxifen had about a 50% lower likelihood of developing a brand new second breast cancer in their other breast. And that gave rise to the concept of, can we use tamoxifen to prevent breast cancer in women who have never had a breast cancer? If we look at studies that are designed to try to do this, there are really three things that we have to be able to accomplish in order to have that happen. The first is that we need to be able to identify a high-risk group of women for breast cancer, because if a woman's not going to develop breast cancer, the intervention is simply not necessary. We need to have available an intervention that will decrease that risk, and there is the potential that agents such as tamoxifen will do that. And because these women are healthy when they enter the trial or enter treatment, these agents must be of very low toxicity, because given the average yearly risk for a woman to develop breast cancer, even a high-risk woman, is quite low. So the toxicity experience must be extraordinarily favorable. So if we look at how can we identify or estimate a given woman's risk for breast cancer, one of the models that is widely used, and this model is available to you on the NCI's website, is called the Modified Gale Model, and it looks at a woman's ethnicity, her age, the age she had her first period, the age she had her first child, the number of first-degree relatives who have breast cancer, and whether or not she's had biopsies before, and if she has, the number of biopsies, and whether or not these biopsies showed one of the proliferative benign breast diseases known as atypical hyperplasia. This is a hypothetical woman with data entered into the Gale model. She's 54 years of age, Caucasian. She had a mother with breast cancer, had her first period at age 13. Her first child was born at age 26, and she had one prior biopsy that showed simply a fibroadenoma. So the Gale model actually estimates that this woman's risk of developing breast cancer is 1.83% at 5 years. So it's about a 1 in 350 per year chance in the next 5 years of developing breast cancer. And her lifetime risk is estimated at about 13%. So this is a woman who's at actually moderately increased relative risk for developing breast cancer, but as you can see, the absolute risks that even a high-risk woman has are relatively modest. The breast cancer prevention trial that has been reported and that we have 7-year follow-up data on addressed the issue of tamoxifen as a chemopreventive agent. This trial identified women who were 35 years of age or older, who had no prior history of breast cancer themselves, and who had a 5-year risk, according to this Gale model, of at least 1.66%. That 1.66% was selected because that is the average risk of the average 60-year-old woman in the United States. And these women were then randomized to tamoxifen or placebo. It was an enormous study. There were over 13,000 women enrolled in this trial. This shows the data when last published, looking at the frequency of invasive and non-invasive breast cancers. The number of invasive breast cancers on the tamoxifen-treated group are shown here in the blue, and in the placebo group in the gold. And as you can see, the use of tamoxifen decreased by about 50% the likelihood of a woman developing an invasive breast cancer. A similar finding with non-invasive breast cancers is shown here, and so overall, again, about a 50% reduction in the occurrences of invasive and non-invasive breast cancers. This shows the cumulative risk of developing an invasive breast cancer for the women on this trial. Again, the tamoxifen-treated women are shown in the blue and the placebo-treated women in the gold. And as you can see, the decrease in occurrences of breast cancers occurred very early on in this study. The women were treated with tamoxifen or placebo for 5 years in this trial. And as you can see, even beyond the 5 years where they stopped taking the tamoxifen or the placebo, the curves continued to diverge. So the benefits of tamoxifen appear to continue beyond the time that the women are actually taking the active agent. Now, tamoxifen, as I mentioned earlier, has estrogen-like effects on some organs, and one of those organs is the uterus. And continuous estrogen exposure to the uterus is associated with an increased risk of a woman developing cancer of the uterus, the so-called endometrial cancer. And this shows the experience of endometrial cancer in the prevention trial for women who were under 50 years of age, so these would generally be premenopausal women. The use of tamoxifen did not appear to significantly impact a woman's risk of cancer of the uterus. In the postmenopausal women, however, the experience with tamoxifen was about a 3 to 3.5-fold increased risk of the development of endometrial cancer. And overall, of course, then there was an increased risk as well. So it looks like tamoxifen is associated with a substantial increased risk of cancer of the uterus. However, that increased risk is confined almost exclusively to postmenopausal women, and it's an absolute difference of about 2 to 3%. Estrogens also increase the likelihood that blood will clot, and so the use of tamoxifen had estrogen-like effects on the clotting system. Tamoxifen is associated with a slight increased risk of stroke and of pulmonary emboli or blood clots to the lung, and a slight increased risk of DVTs. Those are blood clots in the deep veins, primarily in the leg. So tamoxifen is associated with an increased risk of blood clots. So the breast cancer prevention trial was really the first trial to show that a chemoprevention intervention could truly decrease the risk of a cancer, and in this case of a common cancer. But we weren't happy with the toxicity experience in the breast cancer prevention trial because while the toxicities were infrequent, they were often, when they did occur, concerning. At the same time that the breast cancer prevention trial with tamoxifen was going on, there was a trial looking at the use of another type of selective estrogen receptor modulator called raloxifene in the treatment of osteoporosis. And there was a suggestion from that trial that raloxifene might decrease the frequency of breast cancer as well, and that the magnitude of benefit might actually be slightly larger than that with tamoxifen. And because of that, the so-called STAR trial, the study of tamoxifen and raloxifene, was initiated. This trial was limited to postmenopausal women who were 35 years of age or older and who had a 1.7% or greater 5-year risk of breast cancer, or that had a benign abnormality called lobular carcinoma in situ that also increases breast cancer risk. And the women were randomized to either tamoxifen or to raloxifene. And as you can see, there were over 19,000 women participating in this trial. The results of this study were first reported just this last June, and this shows the data out to 6 years, looking at the cumulative incidence of invasive breast cancers. And as you can see, there really was no difference in effectiveness between tamoxifen and raloxifene. This shows the incidence of non-invasive breast cancers. And as you can see, in terms of non-invasive breast cancers, it does appear that tamoxifen helps to prevent some, but not all, non-invasive breast cancers and does a better job of that than does raloxifene. Now, non-invasive breast cancers tend not to be threatening to a woman's life, but they're very annoying for her to have treated. They require mastectomy or lumpectomy and radiation therapy, so local treatment very similar to an invasive breast cancer. So the avoidance of a non-invasive breast cancer is definitely a good thing. This shows the cumulative incidence of the cancers of the uterus in this trial. As you can see, raloxifene was associated with fewer cancers of the uterus through the 6 years of follow-up, so less toxicity as it relates to the uterus. This shows the occurrence of blood clots or so-called thromboembolic events in the STAR trial, and throughout the entire 6 years of follow-up available, the women treated with tamoxifen had a higher frequency of blood clots than did the women treated with raloxifene. And finally, cataracts are an uncommon complication that occur in women treated with tamoxifen. And if we look at the experience of cataracts in the tamoxifen versus the raloxifene-treated women, there were slightly more cataracts in the women who were treated with tamoxifen. So if we look at the STAR trial, and in summary, it does appear that raloxifene is as effective as tamoxifen in the prevention of invasive breast cancers. that raloxifene is less effective than tamoxifen in the prevention of non-invasive breast cancer, and that compared to tamoxifen, raloxifene is associated with fewer blood clots, fewer cancers of the uterus, and fewer cataracts. So which of these agents in this trial is the winner? I personally am not sure of. The investigators that led this study have concluded that raloxifene is the winner here because of the similar numbers of invasive breast cancers and a slightly more favorable toxicity profile. So if a woman is to develop breast cancer, how is that breast cancer detected, and are there things that we can do to assure that the breast cancer is detected as early as possible so that the treatment options are as favorable as possible? Well, there are three ways that breast cancer can be screened for or detected on an early basis. One is by the woman performing breast self-examination. This is where the woman herself palpates her breast. Self-breast examination has never been demonstrated to decrease breast cancer mortality or to increase survival from breast cancer. And in fact, the largest study that we have, a study from Shanghai, China, suggests that breast self-examination is of no value whatsoever. Well, what about clinical breast examination? Clinical breast examination is when you go to your gynecologist and your gynecologist examines your breast. Clinical breast examination, likewise, has never been shown to decrease breast cancer mortality. It's a relatively inexpensive therapy or evaluation, however, and sometimes you just get lucky. Screening mammography. Screening mammography has been studied in a number of prospective clinical trials. Tens of thousands of women have participated in these studies, and screening mammography used routinely, at least in women over 50, and probably also in women over the age of 40, is associated with a decrease in breast cancer deaths. So if we look at that, screening mammography is really the only method of early detection that is associated with a decreased breast cancer mortality. Because of this, a number of professional societies have made recommendations about the use of screening mammography, and this slide summarizes four of the larger associations or more influential ones who have issued recommendations in this regard. Essentially, all of the recommendations are that screening mammography should be performed on a routine basis in women over the age of 40. The only disagreement is perhaps that the NCI talks about screening mammography every 1 to 2 years, while all of the other professional societies recommend it on an annual basis. There is an ongoing controversy looking at the use of screening mammography today in terms of looking at what's called film versus digital mammography. So at home you've all got cameras. If you have an old camera, you have film that you put into the camera, take a picture, you get the film developed, you look at the print. We also have digital cameras where all the image is put onto a floppy disk or onto your computer, and you can manipulate it, play with it, change it, and so forth, and that's a digital image. Well, we can do the same in mammography. There are machines that use regular film, X-ray film, to take the image, and there's mammography equipment that utilizes digital mammography or digital equipment to take that same image. There's been a lot of controversy about which of those two techniques is better or worse, or whether they're equivalent. And there was just reported in 2005 a very large study done in almost 50,000 women in the US and Canada who underwent both film mammography and digital mammography on a regular basis. And what they found was that digital and film mammography are of very similar accuracy. However, there were situations in which digital mammography was superior. In women under the age of 50, in women who had dense breasts, and in women who were pre- or perimenopausal. In those subsets, it did look like digital mammography was superior to film mammography. What I'd like to do, hopefully the lights are dim enough, I'd like to show you some examples of comparisons between analog or film and digital mammography. So these are two mammograms taken of the same patient, the same breast, and the same view. This is the film mammography, and this is the digital mammogram. And you can probably see here sort of a starburst-like pattern. That's a breast cancer. You can see it easily here. You can sort of get it here, but you get a much clearer signal with digital mammography. This is another example. Again, film mammography. You can see a suggestion of an abnormality here. It's much clearer in the digital film here. Now, one of the other things that digital mammography allows is the so-called computer-assisted detection of abnormalities. So just like you have with your camera a digital file on your computer that you can modify, when you have the mammograms digitalized as well, the radiologist can play with it, and there are in fact computer programs that will search through the mammogram and point the radiologist to areas that the computer program thinks are concerning. And so the computer basically does a second read, if you will, of the film to assist the radiologist in not missing an abnormality. This is yet another a mammogram. Again, we don't see any clear abnormality here. We see an obvious abnormality here that proved to be a cancer. Well, one of the other techniques that we're using more and more to detect breast cancer is so-called breast MRI scanning. This is magnetic resonance imaging. It's a procedure that's similar to having MRIs of the head or of a knee or a shoulder. The individual is actually placed in a very strong, large magnet, and then the magnetic field is pulsed, and the body's reaction to that pulse of magnetism is sensed by the MRI antenna, and it can actually then take a picture using those pulse sequences. And for the mammogram, the woman actually lays down on this, and the breasts hang down through these squares on both sides. It's called the breast coil. And if you're going to get an accurate MRI scan of the breast, you must have a dedicated breast coil. If the coil will do your knee, it should not do your breast. So this is an example of a regular film mammogram. The right breast, the left breast, the image is taken from the side. The radiologist here has put wires on the breast where there are scars in the skin. It helps them as they read the image. And you can see here a little BB, and the radiologist put a BB on the breast where there's a concerning abnormality on physical examination. So we know that whatever's of interest in this breast is likely to be in this area, and you can look as hard as you want in this area, and I can't see it. So this is an MRI scan of that same breast, same patient, and you can see here that the cancer in this breast stands right out. So it's much, much easier to see. So why don't we do MRI scans all the time? Well, there are a variety of reasons. One is that they're very expensive. It's a limited resource. We would bankrupt the U.S. healthcare system if we started doing screening MRI scans in everyone tomorrow. I'm sorry, this is another MRI scan. Again, a regular mammogram. This is the cancer. Again, stands right out. So if we look at how good is MRI scanning at actually detecting breast cancer, that's shown in this slide that shows some of the larger series looking at MRI scan screening. And this is what we call sensitivity. So sensitivity means that if there is a cancer there, how likely are you to detect it? That's what we call sensitivity. And this looks at MRI scanning in this row and mammograms in this row. And as you can see, if there's a cancer present, MRI scan has about a 78% chance of detecting it. Routine mammography has about a 40% chance. So we almost double our sensitivity by performing MRI scanning as opposed to routine mammography, at least in the selected women who were enrolled in these trials. So why wouldn't we do MRI scanning all the time if money was not a matter? Well, part of it is that MRI scans are so good at detecting abnormalities that they often detect things that prove not to be of concern, prove not to be cancers, but that the radiologist is concerned about, and so recommends a biopsy be done. And this looks now at what we call positive predictive value of the MRI. So positive predictive value means if the radiologist calls this test abnormal, how likely is it that abnormality is really a cancer? And as you can see, the numbers are all over the map. In some series as low as 7%, in some series up into the 40s and 60%. So one of the difficulties with MRI scanning is it not only is an expensive technique, but it is so good that the radiologists are worried about a lot of things that ultimately prove to be normal. And so you have the anxiety, the trauma, the expense, and the discomfort and so on of many unnecessary biopsies. So I'm sure we're going to be hearing a lot more about MRI scanning as the technique becomes more refined and as the technology becomes less costly over the next couple decades. Well, let's turn to treatment now. And in looking at treatment of breast cancer, I'm really going to be glossing, and I'm going to be what we call lumping. There are lumpers and splitters, and I'm really going to be lumping in the next few minutes. And I recognize that it's going to be a very superficial look at to treatment of breast cancer, but I think it will give you a general sense. So when we think about the treatment of breast cancer, there are two major problems we have to concern ourselves with. The first is how best to treat the breast itself and lymph glands around the breast. And then the second problem is whether the rest of the woman needs treated, like with chemotherapy or hormone therapy. And if we look at the first issue, how best to treat the breast, most women, but not all, most women with newly diagnosed breast cancer are appropriate candidates to either have the performance of a mastectomy or what we call breast-conserving therapy. So mastectomy is removal of the entire breast, including the nipple and the colored part around the nipple, and evaluation of the lymph glands from underneath the arm. The muscle is left intact underneath where the breast was, and reconstruction, if the woman desires it, can usually be done at the same time as the mastectomy. Breast-conserving therapy is a situation where the surgeon removes the lump from the breast that contains the cancer, evaluates the lymph glands underneath the arm, and then the radiation therapist treats the rest of the breast that remains behind. And in essentially all of the randomized trials that have been done, and we have 25-year follow-up on some of these trials, the use of breast-conserving therapy is equivalent to mastectomy in overall survival, and that's a very consistent finding. There are, however, selected subgroups of women who are better treated with mastectomy. And these include women with very large tumors, women who have more than one cancer in the same breast, and women who have been previously treated with radiation therapy, so the breast that's left behind cannot be safely treated with additional radiation therapy because of cumulative toxicity to the normal tissues. So when we do the breast-conserving therapy, the woman is not the need for surgery is not prevented. She still requires surgical removal of the tumor, and the whole breast is treated with radiation. This treatment is typically a daily, 5 days a week, for about 6 weeks. So it's a very big commitment of time. There have recently been some efforts to try to shorten the course of radiation therapy, what we call accelerated breast irradiation, and also to narrow the amount of the breast that requires treatment. And we call this accelerated partial breast irradiation. So again, a partial part of the breast is treated, so a dose is delivered to the area where the tumor was removed, plus a margin around that cavity only, and the rest of the breast is not treated. Accelerated means that we give the dose of radiation therapy over over far fewer days. So the dose of radiation therapy is typically given over 1 to 5 days, rather than over 6 weeks or so. There are a number of ways we can do that. One is with the use of interstitial brachytherapy. That's where radiation seeds are actually placed inside the breast. There's another technique that uses a balloon that is put in the lumpectomy cavity with radiation seeds around the outside of the balloon. There's another that's the so-called 3D conformal external beam radiation therapy. That's where there's a very special machine that sweeps through an arc and directs a very narrow beam at a consistent target. And so the whole breast is treated, in fact, but almost all of the area that's in the center of the hub, if you will, of the wheel gets much, much more radiation than the rest of the breast. And then the fourth way is a type of therapy called intraoperative radiotherapy. Let me talk a little bit more about that. So we have a trial ongoing here that's headed by one of our surgeons, Dr. Durbus, and one of our radiation oncologists, Dr. Horst, that is actually looking at one of these accelerated partial breast irradiation methodologies. They have a trial that is limited to women over the age of 40. The tumors have to be relatively small, about 2.5 centimeters or smaller, so about an inch or smaller. No lymph node involvement. They have to have had a breast MRI scan to be certain that there's only the one area of tumor in the breast. And if we treat only the local area, we aren't sparing tumor someplace else in the breast. And then they're treated with intraoperative radiotherapy. Now, to do the intraoperative radiotherapy, what happens is that the surgeon goes in and does a lumpectomy. So this is where this is the breast. The woman's rib cage is here. The surgeon goes in and takes the lump out, and then they place a lead plate in the back here, right along here, and the lead plate is there so that when they aim the radiation at the patient, it doesn't go into their chest or into their heart and affect normal tissues deeper inside the body. And after that lead plate is placed, then the surgeon sews this up so that these tissues come together. And then there's a portable radiotherapy machine in the operating room. The woman is in the operating room under anesthesia. This machine is brought in, placed over her, aimed appropriately. Everybody but the patient leaves the room. The switch is turned. 17 minutes later, the switch is closed. Her treatment is done. They, of course, take the lead plate out. They open the wound, take the lead plate out, sew it back up, and her radiation therapy is done. This trial has been opened since December of 2002. There are approximately 75 patients on this trial so far, and to date we have had no recurrences of breast cancer. This is, however, a highly selected patient population, and the use of any of these partial breast irradiation techniques, in my judgment, at this point in time should be considered investigational or experimental. So after the breast itself is treated and we've evaluated the lymph nodes, we then move on to what we call adjuvant therapy. So adjuvant therapy is chemotherapy, hormone therapy, drug therapy, if you will, that is given to a woman after all of the breast cancer in her system that we can detect has been removed. Now, we know by experience that many women who have breast cancer that appears to be confined to the breast and lymph glands around the breast, that with follow-up they will experience a recurrence of their breast cancer. And presumably those recurrences happen because small numbers of cells have spread from the breast well before the time of surgery and set up housekeeping in other parts of the body, and those cells with time grow and become apparent down the road. So the use of the adjuvant chemotherapy to the whole body is an attempt to try to get to those cells that have already spread outside the breast before the surgeon and radiation therapist have an opportunity to actually treat the tumor in the breast itself. So when we try to make decisions about whether adjuvant therapy should be used, there are three questions that we typically go through in sequence. And the first is, what is the woman's risk for recurrence? If she has a 0 risk of recurrence, then there's no reason to treat her. On the other hand, if she has a 90% chance of recurrence, then we would treat her even with a very toxic or very difficult therapy. The second then is, can we improve her outcome by some form of treatment? And if we can, by about how much? So it's estimating the magnitude of benefit that she's likely to experience. And then the third is, what does she have to put up with in terms of toxicity to experience that improvement in outcome, and is it worth it to her? So we fortunately are assisted by some computer-based models that can help us predict a given woman's outcome. The most widely used model is shown here. It's called Adjuvant. It's available over the internet and on handheld computers free of charge. And this model uses a number of different features that you can input. The first is the woman's age, what we call comorbidity, what her general health status is. Is it excellent, minor problems, very poor? Does her breast cancer contain hormone receptors for estrogen or progesterone? So is it likely to be responsive to the effects of hormones? What does the tumor look like under the microscope, what the pathologists call tumor grade? How big is the tumor? Does the tumor involve the lymph nodes under the armpit, and if so, how much? You can calculate for overall survival. You can also calculate for simply recurrence of breast cancer. And then you can input down here the various therapies that you would consider treating the woman with and get an estimate, and these really are estimates, an estimate of the likelihood of benefit that the woman is likely to experience. And when that's done, this is a picture from a real patient. We can see that if this woman has no additional therapy beyond her local surgery and radiation therapy if appropriate, that she has about an 84% chance of being alive 10 years from the date of diagnosis. The red shows that 7.7% of the time the women with these characteristics will have died of breast cancer at 10 years. And other things of badness can happen to us, and she has about an 8% chance of dying of something else. And then the bar here estimates the benefit in yellow of what would happen if we gave her hormonal therapy, in this case tamoxifen. And then this looks at how much improvement she would likely experience if she received both hormonal therapy with tamoxifen and chemotherapy of a type that's called CMF. And so this really helps physicians and it helps patients, I think, get a sense of how likely the various therapies are to benefit them, as well as simply to look at what their baseline risk of recurrence or of survival really is. So you can complete your oncology fellowship, at least as it relates to breast cancer, if you remember this slide. And that is that women whose tumors have hormone receptors for estrogen or progesterone should receive a hormone as part of their treatment. Women who have a moderate to high risk for recurrence of their breast cancer in this situation should receive chemotherapy. And that if a woman has a breast cancer that is HER2 positive, and I'll talk about that further in just a minute, she should receive treatment with a medication called trastuzumab, also sold by the brand name of Herceptin. So let's look a little bit further at these different therapies. So we've already heard about tamoxifen as a breast cancer prevention agent. This slide shows the benefits of tamoxifen as treatment for women with newly diagnosed breast cancer if their breast cancers are hormone receptor positive or hormone receptor unknown. And most women with hormone receptor unknown breast cancer, in fact, are hormone receptor positive. So you can look at this as a hormone receptor positive family of curves. There's 15 years of follow-up on each of these curves. This shows the likelihood that a woman will experience in that 15 years a recurrence of her breast cancer. And this is for women who are treated with tamoxifen for their hormone responsive breast cancers and women treated without tamoxifen. And as you can see, those women treated with tamoxifen do substantially better than those women who are not given tamoxifen. It's of interest that the tamoxifen treatment in these studies goes for only 5 years, and yet the benefits from tamoxifen persist well beyond the 5 years of treatment. This is the corresponding likelihood of death in these same studies. Again, 15 years of follow-up. Deaths in women treated with tamoxifen, deaths in women not given tamoxifen. Again, tamoxifen substantially decreases the likelihood of death in women who have hormone receptor positive breast cancer. So if we look at where does estrogen come from in women, there are differences between pre- and postmenopausal women. So in the premenopausal woman, most of the estrogen in the system comes from the pituitary gland telling the ovary to make estrogen, and then the ovary releases the estrogen into the circulation. A minor component in the premenopausal woman, and essentially all of the estrogen in the postmenopausal woman, comes from a different system where the pituitary gland tells the adrenal gland to make sex hormones that in fact turn out to be androgens, or male hormones, and those are released into the blood. And then there's an enzyme, a protein, in the fat, in liver, bone, and some breast cancers called the aromatase enzyme that converts that male hormone to estrogen. So most of the estrogen in a postmenopausal woman actually comes from the adrenal gland. Now tamoxifen will block the hormone, the estrogen in the premenopausal woman and in the postmenopausal woman. It really doesn't care where the estrogen has come from. But there's a class of drugs that are called the aromatase inhibitors that block the conversion by the aromatase enzyme of the male hormone to the female hormone in postmenopausal women. That's shown schematically here. So the adrenal gland takes cholesterol and then converts it to a hormone that helps us with salt balance, to cortisol, and to this male hormone, androstenedione. And this male hormone, again, is released into the periphery. The aromatase enzyme converts it to estrone and ultimately to the major estrogen in postmenopausal women, estradiol. The aromatase inhibitors block this conversion, and so the estrone and estradiol in the postmenopausal woman plummets. And these agents are about 90 to 95% effective in reducing circulating estrogen in postmenopausal women. Because in the premenopausal women, most of the estrogen is coming from the ovary, these aromatase inhibitors are not active in the treatment of premenopausal women. I won't go through all the studies, but the aromatase inhibitors in postmenopausal women with metastatic breast cancer have been shown to be at least as effective as tamoxifen in the treatment of metastatic breast cancer. And that raised the possibility that these aromatase inhibitors might be effective in the adjuvant treatment of breast cancer very early on. There have been a whole family of protocols that have been performed looking at the use of tamoxifen alone versus an aromatase inhibitor alone, or various combinations of tamoxifen and an aromatase inhibitor. I'm going to show you the data from the first of these studies that was reported, and the one, therefore, that we have the longest follow-up. This is the so-called ATAC trial. All were postmenopausal women. They had invasive breast cancer. They had their local therapy, and they could have received chemotherapy or not, depending on what they wished and what their physician wished. And then they were randomized to either an aromatase inhibitor called anastrozole and a tamoxifen placebo, or to an anastrozole placebo plus tamoxifen, an active tamoxifen, or to both the aromatase inhibitor and tamoxifen. Now, much to everyone's surprise, the women treated with the aromatase inhibitor and tamoxifen did not do better than women treated with tamoxifen alone. So the only comparison here that's really of interest is anastrozole versus tamoxifen. This shows what we call the disease-free survival of the women in this trial. So be careful here about the y-axis. This is from 0 to 25%. It's not 100%. And across here we have years of follow-up, with up to 6 years of follow-up available at this time. And this shows the cumulative number of women experiencing a recurrence of their breast cancer, with the anastrozole shown in the magenta line and tamoxifen shown in the blue line. And as you can see, there were fewer recurrences of breast cancer in the women treated with anastrozole than tamoxifen, although the differences were modest. This shows the overall survival in this same study. And as you can see, there is no meaningful difference in survival throughout 6 years of follow-up in this trial. So the aromatase inhibitors, at least as used in the ATAC trial, do appear to be superior to tamoxifen in keeping cancer away, but not necessarily superior in terms of keeping women alive. If we look at the use of chemotherapy in women with breast cancer, there are dozens, actually hundreds of studies that are available. Because there are so many studies available, if you pick and choose your study correctly, you can justify doing pretty much anything that you want. There's a technique, though, that's called overview analysis. It's also called meta-analysis. It's a very powerful statistical technique where you can take studies of similar design and analyze them together. And so it averages out the outlier study. And this sort of meta-analysis has been done by a group called the Early Breast Cancer Trialists group that is an international group that has looked specifically at the impact of chemotherapy in breast cancer. And this slide outlines some of their results. It's a bit tricky to interpret because the statisticians do these studies, not clinicians. And what these bars show is the reduction in a woman's likelihood of recurrence in any given year. So if a woman has a 20% likelihood of recurrence per year, you can reduce that likelihood of recurrence by 50%. And that 50% of 20% is 10%. And so you would reduce her likelihood of recurrence down to 10% per year. That's a 50% reduction. And that's how these numbers are displayed. So a high number here, a big bar, is good. And what we see are the magnitudes of benefit from chemotherapy in women under the age of 40, women 40 to 49, 50 to 59, 60 to 69, and 70 years of age or older. And looking at the likelihood that the chemotherapy will reduce their likelihood of death in the blue and reduce their likelihood of recurrence of breast cancer in the yellow. And as you can see, all age groups of women appear to benefit from the use of chemotherapy in the treatment of their breast cancers, although the benefits decrease with increasing age. And I'm not going to show you the data, but there's also very recent analyses that would suggest that especially the older woman who has a hormone receptor positive breast cancer and receives hormone therapy, that her benefit from chemotherapy may be extraordinarily small, if there's any benefit at all. Okay, bear with me. We're going to have a brief biology lesson. So what about trastuzumab or Herceptin? So one of the methods that cells use to make things happen and for the body to communicate with other parts of the cells are through special receptors that are on the cell surface. And there are different types of these receptors. They're proteins that are on the cell surfaces that are called protein tyrosine kinases. These tyrosine kinase receptors tend to have things in common. They include a part of the protein that is on the outside surface of the cell, and then there's a little bridge here that connects the outside part of this protein with the inside, the part of the protein that's inside the cell. It's called the bridging segment. And then there's the inside part, and the inside part here has what's called the tyrosine kinase. It's an enzyme. It does things in the cell. It puts phosphate molecules on other proteins. So on almost all of our cells, and especially cancer cells, there are a number of these different tyrosine kinase proteins that can exist. And one of these proteins is called the HER2 protein, human epidermal growth factor receptor 2. There are 4 of them, 1, 2, 3, 4. We're talking about HER2, the second one in the series. And these proteins exist as what we call monomers outside the cell. And then there are ligands, these little they're things that circulate in the blood, in the fluids. They come and they glop onto these receptors. And when these ligands glomp onto these receptors, they tell these receptors, it's time to dance. And what do you do when you dance? You find a partner. And these proteins, these monomer units come together and they form what we call dimers. And that basically means that they're dancing. And when they're dancing, they're not only dancing with their tops, they're dancing with their bottoms. And what happens is that these two arms that are inside the cell come close together and they put a phosphate on each other's knees. And then what happens is those phosphates do a whole bunch of things in the cell that aren't important for you to know about. But the things that those phosphates then do inside the cell have a lot of influences and a lot of effects on the cells inside. And the general effect with HER2, when it's activated, is that it causes the cell to grow. And if you're a cancer, if you have a cancer, you don't want the HER2 signal to be active because it will be telling your cancer to grow. So there are different ways that we can try to tell these tyrosine kinase receptors not to cause that signaling inside the cell, to prevent the dance from happening. One way is by the use of monoclonal antibodies, and they typically target the outside part of the receptor, but not always. And then there is the so-called tyrosine kinase inhibitors. These are small medicines that prevent the inside part of this receptor from working. Now, trastuzumab, or Herceptin, that is widely used now in the treatment of breast cancer, is an antibody that attacks the outside portion of this receptor. There have recently been a number of studies reported looking at the use of trastuzumab in the treatment of breast cancers that have too much of this receptor on the cell surface. The schema of 3 of these studies is shown here. Let's look at the first 2 of them only. So one of them is called NSABP B31. These women all had invasive breast cancer, and their breast cancers had too much of this HER2 protein. They were given standard chemotherapy, shown in the blue, a chemotherapy called AC chemotherapy for 4 treatments, and then they were given 4 treatments of a standard chemotherapy called Taxol, or paclitaxel. They were divided into 2 groups, the group that got chemotherapy alone, and the group that, starting with the paclitaxel, started getting this trastuzumab, this antibody against their HER2. And the antibody was continued for a year. Another of the studies, shown here, was done by another research group, had very similar design, the same AC chemotherapy. It also had Taxol, except the Taxol, instead of being given every 3 weeks, was given every week for 12 doses. And in some of the women, the Herceptin, or the trastuzumab, was started after all the chemotherapy was done. And in the other group, the trastuzumab was started with the Taxol. Now, what these investigators did was they realized that arm 1 here is very similar to arm A here, and arm 2 here is very similar to arm C here. And so in order to try to get an answer from these studies earlier, they did an analysis where they merged their 2 studies together, the 2 arms of each study that were similar. And this shows the result of that analysis. We have 5 years of follow-up shown here, and on the y-axis here are the number of women remaining free of recurrence of their breast cancer. And the top line here are those women who, as part of their treatment, received the trastuzumab, and these are the women who received only the chemotherapy. And as you can see, the women who received the trastuzumab had a huge improvement in their likelihood of doing well, about almost a 20% improvement in being free of a recurrence of breast cancer at only 4 years of follow-up. And I won't show you the data because we don't have time, but there now is emerging in this data a survival advantage as well to the women who were treated with the trastuzumab. There are a number of other studies that have looked at similar questions using trastuzumab, and they all show consistent benefits of the same order of magnitude to the incorporation of trastuzumab. So let me end again with a little bit about what I was talking about earlier at the very beginning, and that is that most women who are diagnosed with breast cancer do not die of breast cancer. And this figure shows that we're actually, with time, with the improvement in diagnostics that we have and the improvement in therapeutics that we have, doing better and better. What this shows is from 1985, it shows women who were diagnosed in 1985 to women who were diagnosed in 1998 with breast cancer. And the percentage of those women diagnosed in that year who were 5-year survivors. So it shows that if a woman was diagnosed in 1985, the chance that she would be alive 5 years from the time of her diagnosis was about 80%. In 1998, that has now improved to about 90%. So we've actually reduced about half of the deaths that would have occurred from breast cancer by 5 years anyway, between 1985 and 1998. And the yellow line shows the corresponding 10-year survival figures, and as you can see, we're improving as we would expect in 10-year survival as well. We obviously don't have more recent data because these women haven't been alive long enough to live 10 years. So with that, I thank you for your attention.